All right, good day to everybody. So this is a case discussion, and what we have here is a AP lateral of this patient's distal tibia and ankle. Okay, it is slightly mature, and I note the presence of a fracture of the tibia. There is comminution, but at the same time, it is minimally displaced both on the AP as well as the lateral view. Given this X-ray, I will first want to stabilize the patient according to ATRS principles, ensure airway, breathing, circulation is intact. I'll then take a history regard to the mechanism of injury. Based on this fracture pattern, I expect to find a direct impact to this shin, all right, as I do not know any spiral or oblique pattern to this. I will then make sure there's no prodromal pain and make sure there's no other significant past medical history that may affect the management. Thereafter, in this patient with a tibia shaft fracture, I want to examine for any open wounds, making sure this is not an open fracture. Number two, I'm going to check the neurovascular status of this limb by checking the posterior tibial and the dorsalis pedis pulses, ensuring there's no foot drop and there's no loss of sensation distally. Thirdly, I will do a secondary survey to look for any pain around the ankle as well as the knee joint, as well as elsewhere using a face compression, chest compression, and ensuring there are no other injuries in my secondary survey. And finally, in this case, I want to make sure there's no compartment syndrome, which is particularly prone in tibia shaft fractures. Next, this is my initial investigation. I will then go on to acute management. All right, in this case, there is no need for any manipulation and reduction as the fracture is minimally displaced. I will go on to do a temporary stabilization using a above knee back snap to really stabilize the fracture in the tibial shaft. Next, box number 6. Because this is a shaft fracture, it is not near the joint. I do not need any further advanced imaging. The next question is for definitive management. Based on this fracture pattern, definitely this can be treated either non-operative or operatively. Non-operatively would involve changing to a full cast in 2 weeks, which is circumferential, and leaving it on with the patient non-weight bearing for at least 6 weeks. That's a pretty long period of reduced mobility. The next option is surgical fixation, and this will be utilizing a intramedullary device, of which the benefit is to allow the patient immediate full weight bearing as tolerated, meaning straight after the surgery, the patient will be allowed to walk because the metal will be able to bear the weight of the patient's bone. All right, so I think that was chosen. In terms of counseling for this patient for surgery, I will describe the possibility of non-operative management. Okay, the advantage of surgical management, which is immediate weight bearing. Secondly, I will talk about the risk. The risk is general anesthesia, risk of heart attack, stroke, death less than 1%. If the patient is not a smoker, no past medical problem, the risks are relatively low. The specific risk for this surgery will be number 1, intraoperatively neurovascular injury. All right, risk of infection, which may require multiple surgeries to wash out the bone and debride. So to prevent that, we'll give the patient prophylactic antibiotics to prevent infection. After the surgery, there's risk of compartment syndrome. There's a risk of deep vein thrombosis should the patient not be walking too much, right? So we got to get the patient to be complying to physiotherapy. Other than that, in terms of fracture fixation, there's always a risk of non-union, malunion. Okay, so that will be the consent taking for this patient. So therefore, this patient undergo intramedullary nailing. You can see that this is an image intensifier photo showing how we insert a guide wire. Using the guide wire to guide us, we then do an opening rim of the proximal tibia. We then insert a guide wire all the way down to the tibia. And with the guide wire's help, we insert the nail and the corresponding interlocking screws. Postoperatively, we will assess the patient's vitals, assess the patient wounds. No drains will be used in this surgery. Prophylactic antibiotics will be given. Physiotherapy instructions should be full weight bear as tolerated. This is a post-operative X-ray. We can see an intramedullary device. All right, you can see the rod going down, typically made of titanium, going down the medullary the canal of the bone. You can see the interlocking screws stabilizing it. All right, so this patient will be allowed to weight bear tolerated immediately, and we will follow up with X-rays of the fracture site to look for bony union. Thereafter, you may ask, must we always remove the implant? No, right? This patient is actually aged about 50, so there's no need to remove the implants. In younger patients, we also usually do not remove the implants, all right? Unless the patient develops symptomatic problems, sometimes such as abrasion with the adjacent soft tissue, but that's hardly the case. All right, I hope you enjoyed the case discussion. I will see you again the next time round. Feel free to send me your cases and we can talk about them on this platform.